So we have presented some data at the BTOG 2019 conference this week, looking at the use of Osimertinib, which is a third-generation EGFR inhibitor, as a second-line therapy in patients with an EGFR mutation who have progressed following first-line EGFR tyrosine kinase inhibitor treatment. Now, we know this is a licensed indication from the drug, and what the data would suggest previously is that around 2/3 of people who progress on first-line TKI have a resistance T790M resistance mutation. So the suggestion might be, if that's the case, around 2/3 of patients go on to receive Osimertinib. And we wanted to see if this was really the case in the real world, because it has impacts on any health economic evaluation one might make. So we looked across a number of hospitals in West London, around 50 patients. And what we found, interestingly, was only around 2/3 of patients were actually being tested for whether they had a T790M mutation when their cancer progressed, much less than we'd expected. Also interestingly, when we looked at the number of patients who actually received Osimertinib as a second-line treatment, it was less than 30%, so less than half than that we would expect. And I think this is important because we need to make sure that any health economic evaluation about providing Osimertinib as a first-line treatment, which is what we're going to be looking at, takes into account real-world second-line data. The significance of the data regarding Osimertinib is that there's an ongoing assessment by NICE, National Institute of Health and Clinical Excellence, regarding the approval of Osimertinib as a first-line treatment. And of course, any assessment of that, it needs to compare Osimertinib as a first-line treatment to Osimertinib as a second-line treatment. And I think if we can use real-world data to inform its role and its likely use in the second-line setting, then that's valuable.